Hi everyone, it's Dr. Derek here from AduMed. In today's video, we'll take a look at haemochromatosis. This is known as an autosomal recessive condition, which essentially means that siblings have around a 25% chance of actually getting this condition. It's really common in our Caucasians, most notably in our Northern Europeans, and is caused by a mutation of the HAV gene on chromosome 6. So the main problem with this condition is that of iron overload. Iron basically gets deposited everywhere, such as the heart, the pancreas, the liver, the joints, amongst many different organs. It's basically everywhere. And because how it affects so many different organs, you can get so many different manifestations of this disease. So let's look at all of this in a bit more detail. Many patients with this condition remain asymptomatic throughout life and are therefore diagnosed following a routine blood test showing abnormal LFTs or a high ferritin. Now, an interesting point to note is that many women present with symptoms after menopause as they lose the protective effect that menstruation has on iron overload. So our symptoms tend to be non-specific, such as lethargy or tiredness all the time, joint aches, abdominal symptoms, impotence or reduced libido. Our classical examination presentation of a bronze skin pigmentation is not as common anymore, as this is due to late presentation due to end organ damage. Some of our risk factors include being a male, a family history of this condition, and increase in age. Now, there are different organs that can be affected by haemochromatosis. As you can see, there are so many different ways this disease can present depending on which organ is affected. If we're suspecting a diagnosis, then it's important that we arrange some blood tests to also check for a full blood count, our iron studies, and a ferritin. Within the iron studies, we also look out for a transferrin, which is basically a protein that helps to transport iron, and it's really important in diagnosing this condition. In addition to all of this, it's important to remember that ferritin is an acute phase reactant, so its levels may be affected by infection and inflammation as well. When we check our blood test and the transferrin level is above 45%, then we may need to arrange a gene testing to actually get to a full conclusion and diagnosis of this condition. Let's now have a think about our management of this condition. Once the diagnosis is made, then our patients who are usually fit enough will then move on to having weekly venesections. In patients who cannot tolerate venesections, iron chelating treatment may be considered. The aim will be a ferritin level of 20 to 30 and a transferrin saturation of less than 50%. Once the diagnosis is made, then we also need to offer the patient's relatives genetic testing and other tests in order to confirm if they also have this condition. So that brings us to the end of today's video, where we've taken a detailed look into what you need to know about haemochromatosis. As always, if you found it helpful, don't forget to leave a like and subscribe. I've also attached a link to a playlist where I think you find loads of other videos that you find really helpful. Until the next time, I'll see you soon.